Thank you very much. I'd first like to thank the people that have invited me here, in particular Dr. Mansour. It's been a pleasure to come here, and I feel like I've kind of gone 360 degrees. My days working in IVF began kind of in Egypt, and I hope they're not over yet in Egypt, but they've brought me here. I first began working in IVF. I was a molecular biologist, but I'd done a lot of work in embryo transfer in cattle. And while I was at the Salk Institute, I was contacted by Mustafa Abu Zaid, and he gave me my first job in Michigan, and that's where I began doing IVF, is working with Mustafa. So it's a pleasure now to come back and return here. And I was actually very much enjoyed as I walked out of the last section and ran into Muhammad Fazi, who I have talked with for over 8 years on the internet and have never met, and finally been able to meet him. So this has been a very pleasant experience for me, and I thank you. Instructing people how to warm eggs, and I travel throughout the world doing that. And I've picked up some secrets that I hope will be of benefit to you as you continue your egg freezing and try to perfect it. Knowledge is the power, but wisdom is the good use of knowledge. So one must have knowledge first in order to have wisdom. And I hope that I will give you some of that knowledge that will help you make wise decisions in what you do with eggs when you want to vitrify them. And I'll mainly be addressing vitrification of oocytes, although any of this is applicable to blastocysts also. Vitrification has changed how we practice medicine. We can really rely on embryos, vitrifying them, and using them for future pregnancies. It's not like when we used to freeze 8-cell embryos by slow cooling, or 2- and 4-cell embryos by slow cooling. We might have a pregnancy rate of 20%. But with vitrification, it's often possible to have a pregnancy rate of around 50%. Part of this is because we're, once again, vitrifying blastocysts, which are much more advanced and will tend to develop into pregnancies a lot more readily than the 8-cell embryo. But vitrification also allows us to treat patients more safely. We don't have to put in as many embryos. We can afford to put in one embryo and vitrify the rest, knowing that there's a very, very good probability they will all survive and they will all be great for transfer. Also, if we have a case where we have severe ovarian hyperstimulation syndrome, we can also vitrify everything. We don't have to gamble and place back an embryo hoping that the patient doesn't get sick. The technique that we actually use to vitrify embryos and oocytes is ultra-rapid cooling. And what we're trying to obtain is vitrification. And that's a very important distinction, because when we were doing slow cooling, in fact, that embryo was undergoing vitrification. There's good evidence that in slow cooling, embryos were being vitrified. Now we're doing vitrification, but we're trying to vitrify both the intracellular and the extracellular fluids. Let's see. Okay, I'm doing something wrong here. There we go. So these are a couple things that I've already brought into up. One of the most common problems that I've seen as we begin doing vitrification is that when I am working in a lab, it's often felt that to vitrify oocytes, I just need to do the same thing that I do for vitrifying blastocysts. And this is usually an error, because as you'll see through this presentation, the blastocyst can handle a lot more. The cells are smaller, and the membrane of the blastocyst is much more permeable than the oocyte. So you can have a little bit of slop in not having the right temperature, or having more time or less time, and you can still successfully vitrify a blastocyst. First, let's investigate why we do what we do. Why do we vitrify oocytes and blastocysts the way I've mentioned? First of all, here's a short quiz for each of you. If you want to answer these questions in your head, and then I'll go over the answers at the end. Does vitrification occur in slow cooling? I think I've already answered that one. It does. Does recrystallization or devitrification always result in cell death? Third, do current vitrification methods reach equilibrium, meaning you have the same concentration of vitrificants outside as you do inside of the cell? Also, why do we use 2 cryoprotectants usually when we vitrify instead of 1? And finally, is the intracellular concentration of the cryoprotectants higher in slow or ultra-rapid cooling? And some of these answers might surprise you. First of all, in vitrification, our goal is to get the solutions to form a glass. When we have a glass, there is no translational movement. There's no rotational movement of these molecules. There's only vibrational movement. So everything is frozen, but it's not in a crystalline, organized way. It's often been referred to as a non-crystalline amorphous solid. The slower the cooling or the warming rate, the higher the probability of forming ice crystals. And it is these ice crystals that form, especially if they are large, that will damage cells. In cooling, and especially in warming, we need to have a rapid enough rate to get through to what we call the glass transition temperature, the temperature at which a glass can form, which for the solutions that we use is about -110 to -120 degrees centigrade. If we don't get that from room temperature to that glass transition temperature fast enough, ice crystals will grow. And as you waste more time getting there, the ice crystals will get larger. Ice crystals damage tissue by slicing through them. It's a mechanical process, just as you'd imagine. Not only is tissue damaged, but more importantly, cells are destroyed. The larger the ice crystals, the more the damage is done. When there's water and ice during warming or even cooling, sometimes you can have both of those forming before glass formation occurs or before the glass melts. And when you have that, you could have a sheet of ice that would make shear energy that could go ahead and damage your egg or your blastocysts. And I think oftentimes when we see these cracked zonas from vitrification, it's probably not the small ice crystals that have caused this, but it's probably the shear energy of this ice front as it moves through the solution, and we've made some error. There's evidence that the primary damage to vitrified cells is due to this process called recrystallization. So that is what happens as it's warm, as a cell is warmed, you have ice crystals that form. To avoid this damage, there have been a lot of techniques that have been developed to avoid this, but it's kind of a balancing act. The process involves trying to get a rapid cooling or warming and get to the glass transition temperature or above to room temperature as quickly as possible. This is just one typical protocol used for vitrification of oocytes, and I just wanted to show it up here as a demonstration of what is commonly used. This is a Kitasato method. As you can see, we have ethylene glycol and DMSO that are both mixed together in equal proportions. And this was discovered quite a while ago that you could decrease the toxicity of these cryoprotectants, which can be toxic at these high concentrations. Because if you want 30% of cryoprotectant, you can actually get the same concentration by having 15% of ethylene glycol and 15% of DMSO. And they'd be just as effective, but they would be less toxic because each of those probably affects the cells in a different method, causing the toxic problems. This also shows that there's about a 15 to 20 minute exposure to the ES solution, the equilibration solution, which is the 7.5% concentration. Then 60 seconds in the vitrification solution. This shows it goes through 2 steps of vitrification solution, and then a very quick plunge into liquid nitrogen. The cooling rate when we do this in an open device is probably in excess of 20,000 degrees centigrade per minute. If we use a closed device, the cooling rate is probably in the range, if it's a closed device and you plunge the whole device, it's probably around 2,000 degrees centigrade per minute. So there's a tenfold difference in cooling rate and also in the warming rate, depending on whether we use a closed device. A closed device is a device that has a cap that's placed on it that is impermeable, and then you plunge it into liquid nitrogen. An open device, the eggs are placed onto the device and the actual oocytes contact the liquid nitrogen, and then you place a cap on them. So the open device cools down more rapidly and warms up more rapidly. This is a typical warming protocol. Sometimes you'll have people refer to it as a thaw protocol, which probably isn't as correct, but you'll still hear that, and it's hard not to say it when one of the solutions we use is commonly called TS, for thawing solution. But you can see the TS here. It's very important that it is at 37 degrees centigrade. It needs to have a large enough volume so that the mass of the device that you are placing into the solution, so that it will not affect the temperature of the solution. Because if you have very small volume, you place the device into the solution and it will chill that solution, and you won't reach the rapid warming rate that you want to obtain. Then it goes into a dilution. That first solution is 1 molar sucrose. The second solution, DS, is a 1/2 molar sucrose. And then the next two are culture media, but they have, they're usually are heaps-based media so that you can use them on the bench top. We normally try to warm up these oocytes with about 2 hours prior to ICSI, somewhere between 2 and 3 hours. Two things happen to the ova when they're placed into the TS, the warming solution, that are very important and that make it difficult for most people that aren't used to this. First of all, the oocytes turn almost transparent. They almost become invisible. If your microscope, if your stereoscope is not set up correctly, you actually may not see this. You may not find the oocyte. You have to have the angle of the mirror exact so that it refracts off so that you can see the oocyte. The second thing that most people forget is you need to have your microscope adjusted for coal illumination. And this means for the microscopes that we use sometimes, there's an iris on it, and we need to shut that iris down so that it's only 80% open. And those two things will help people greatly in observing these oocytes, because as soon as they touch the warm media, they will be totally clear. No one warned me of this ahead of time, and when I saw these oocytes turn clear, I thought I've done something wrong to them. And when I saw oocytes that looked fine and never turned clear, I thought, oh, those are the good ones. But I was wrong. If you see the oocyte, it doesn't turn clear, it's not going to survive. It will die. The other thing that makes it very difficult is that these oocytes float. So you place them in the media, they turn translucent, and then they float out of focus. So it's very important to be able to pipette the oocytes very rapidly, either off the device, but most of the times you have to do it off the top of the drop. And that takes a special skill for an embryologist to develop that. Most embryologists have already learned how to do that. So why are the cryoprotectants needed at such high concentrations? And why are the steps done the way that I've outlined them here? First is liquid nitrogen is usually used to cool down these devices and the oocytes. And it will help determine how quickly that oocyte will reach the glass transition temperature. Second, as I mentioned previously, it must get to this temperature rapidly. If it doesn't, if it goes leisurely, ice crystals are going to form and they could damage the oocyte. So how can you get to this glass transition temperature quickly? First of all, it's how cold the liquid is. So the liquid nitrogen that we use, you can use other gases, liquid gases. You can use a slush of liquid nitrogen, and that often can accelerate the cooling temperature by using that slush. Now, if we had pure water with no cryoprotectant in it, and let's say we were using a 0.5 microliter volume, it would take us approximately a rate of 80 million centigrade per minute to get it vitrified. So that's not possible for us today. So we use things to help us be able to vitrify these at a rate that we can obtain with liquid nitrogen. And that's why we use the cryoprotectants. The cryoprotectants at high concentration allow us to be able to vitrify at a cooling rate of about 20,000 degrees centigrade per minute. We can also, if we want to enhance the cooling rate, we can make the drops smaller. So if you put a drop down with the oocytes or embryos in and they're very large, then your cooling rate will be slower. If you make the drops smaller, it will be much more rapid. And that's probably the easiest way to increase the cooling rate. I'm going to skip this. So there's a fight that's going on as you're trying to vitrify. As I mentioned, these cryoprotectants are toxic. You want to expose these cells to the cryoprotectants for the shortest amount of time possible. And you don't want to expose them to much larger concentrations of these cryoprotectants. But at the same time, you have to allow enough time for these cryoprotectants to get into the cell. And that is determined by such factors like the permeability of the membrane. To describe this, imagine for a minute that you have a house. You have two houses. They're identical. They're both filled all the way full of nitrogen gas. There's no oxygen in there. One house has the doors and the windows open, and the other is closed tight. Which one is going to take the longest for oxygen and air to slowly seep in through just natural diffusion? Well, the one that's going to be the slowest is the one that's all closed up, right? That's very easy to see. Sometimes we forget about this when we're thinking about vitrification, but this is what happens in vitrification. And a lot of this depends on the permeability of the membrane. And I would like to propose to you that the blastocyst is like that house that has its doors and its windows open. And the oocyte has the doors and the windows closed. Let's talk for a minute about the toxicity of these cryoprotectants just very briefly before I get into membrane permeability. When we see embryos that are destroyed by the cryoprotectants, it's often because the embryos are denaturing the proteins. If you cook an egg, the albumin, the white, goes from this clear translucent color to this white color, and you can't change it back. The same thing happens if you've ever had ceviche, fish that has been cooked with an acid. Although it's raw fish, it's been cooked with an acid, it has denatured the proteins. You can't change it. Well, these cryoprotectants can denature the proteins in the oocyte. They literally can cook the egg. And what it does is it doesn't disrupt the order of the amino acids in the protein, but it changes their secondary, their tertiary, and their quaternary structure. In other words, the beta helices, the beta sheets, those are destroyed. The alpha helices, those are destroyed. Any disulfide bonds, those are destroyed. And oftentimes this is irreversible. So having these cells exposed too long to cryoprotectant can basically cook our cells and make them so that they'd be totally unviable. Now, in order to avoid this, we need to try to get the solutions, the cryoprotectants, into the cells as quickly as possible. Well, this is one method that can happen. I mentioned diffusion. This is passive diffusion, where if you put something in a high concentration, the molecules will bounce around and slowly move into an area of lower concentration. Now, in cells, we have several methods of transport into a cell membrane. I'm going to disregard the active transport, which requires energy, and that's the one that's over here, or the carrier-mediated also, and talk about two methods of briefly of passive transport. First, simple diffusion we've talked about. That is where the thermal energy, the kinetic energy of the molecules bounce around, and they then will find a place of lower concentration where they will enter. In the cell membrane, this is difficult because the cell membrane, remember, is a bipolar membrane. It doesn't want to let in polar molecules. Yet these cryoprotectants are polar molecules. We don't know how, but they can get in through passive diffusion through the cell membrane. So it's like trying to get air into a house where the windows and the doors are closed. There are some small cracks where they'll get in. But the other thing that we see is channel-mediated transport. This is usually facilitated by such proteins as aquaporins. Aquaporins are proteins that form channels, and in general, they only permit the passage of pure water through them in and outside of a cell. But there is an aquaporin that will allow ethylene glycol and other cryoprotectants in and out, and it is called aquaporin 3. So when people have examined blastocysts and oocytes for aquaporin 3, you can imagine what they found. Aquaporin 3 is found in blastomeres. There's holes punched through the cells. There's little pores or channels. But there is no aquaporin 3 that is found in the oocyte. And this is in part what makes the oocyte much less permeable, and which means we must allow more time or increase the temperature in order to get solutions to move in and outside of the cell. If we therefore try to vitrify and especially warm oocytes like we do blastocysts, we may not be giving them enough time. And I think the most common problem I see is that protocols have been developed that work fine for blastocysts, where the time in the ES solution might be 5 minutes or 10 minutes, where in reality it might really need 15 or 20 minutes to get those cryoprotectants out of the cell when you're doing the warming. This is just a diagram of an aquaporin. You can see it has a channel here. It has some guards here that keep out maybe cations or anions, and it only allows pure water to flow in and out. But aquaporin 3 will allow ethylene glycol, we know, to go through the pores. So let's talk for a minute about the permeability of the cells. Remember that the practical outcome is oocytes require more time and higher temperatures to get the same amount of cryoprotectant or water inside and out of a cell when compared to an embryo. It appears that most cooling methods using most carriers, whether the carrier is an open system or a closed system, that the cooling temperature is sufficient to allow for glass formation. The problem comes, though, when we talk about looking at warming temperatures. So this is a nice study that was done by Mazur and Secchi. And this was done on mouse oocytes. The important thing to watch here is this top line up here. Notice that each of these lines is a different warming rate. So this is a low warming rate. This is a high warming rate. And over here is the cooling rate. When they used a warm, rapid warming rate, you can see right here, it did not matter what the cooling rate was. Even at 100 degrees centigrade per minute, that was sufficient to be able to have vitrification and survival of these oocytes. So what the take-home message for this is, the most important part of vitrification or ultra-rapid cooling is probably what is the temperature at which you're warming your cells. And in most cases, you could use an open or closed device, and you'd have sufficient cooling velocity, but it would be inadequate for warming potentially. Or it could be on the border, depending on how you do things. And I think that is what we see, is that we see often we make minor changes that change that warming rate from being sufficient to being insufficient, and we have recrystallization that occurs. So let's look for a second at what can happen in your techniques. This is the applied part of the lecture. So this started for me because I was at a new institute. I was working and I was asked to try to troubleshoot their problems they were having with warming of vitrified banked ova. And when I was there, I started from the beginning, and I started doing a QC analysis of all the parts of their warming. And what I found out is there are many places in warming where we can make small errors that can add up to significant outcomes. So first of all, you look at improper QC. As I've gone around to different clinics, I've measured the temperature of the fluid that they're warming for warming oocytes with an independent thermocouple. And I found some where the incubator says 37 degrees, and when I measure with the thermocouple, it says 33 degrees. And I don't know if that is too cool or not, but I don't think it's a good quality control, and it can add up to problems. What happens is too often we think that the incubators that we use for warming aren't as important as the incubators that we use for culturing of embryos. And I should mention that these incubators should not have CO2 in them. You should turn the CO2 off, or you're going to potentially acidify the media, which could damage the eggs. And the other thing is you should never use a warm block. Warm blocks are much too problematic. They don't always contact the edges of the cryovials that we want to warm the media in. The third thing is we should always try to dump the media into the dish instead of taking what seems like the very sterile practice of pipetting it. And the reason is if we pipette it, we lower the temperature 4 to 5 degrees. If we invert the tube, some embryologists have a habit of taking the tube out, inverting it once or twice to mix it, and then dumping it in. If you do that, you're going to lower it 1 to 2 degrees. And finally, if you don't properly warm your dish, you'll lower it 1 to 2 degrees. So you start out trying to go for 37 degrees, and you end up maybe going for 27 or 22 degrees, which is it might work for a blastocyst, but you're going to have problems. It will increase the probability of recrystallization in the oocyte. So here's my take-home message now that I've got just 3 slides left. First, ova are not embryos. The permeability of the membranes is different. You need to develop the skills of vitrifying and warming ova separately from your blastocyst skills, just like your skills for ICSI are developed separately from your hatching skills. Because of the differences in the membrane permeability and the increased volume of an ovum, remember, they're one large cell as opposed to many small cells, that what you do for an ova may not work with blastocysts. Next, because of differences in temperature, in membrane permeability, temperature and time are going to be more critical for ova. Third, you need to validate your system. You need to have a thermocouple that will measure the temperature of the solutions that you're using. By the third warming, your solution should still be between 36 and 37 degrees centigrade. If not, you need to get a different warming device. Measure the temperatures of test media. You don't have to have cryoprotectant in a tube to measure it. Water works just as well. Put it at the exact same volume and then measure it after a half hour. All the systems I've used indicate that after a half hour, if you put about 1.5 to 3 mLs in a tube, it will be up to the temperature of that device that you've placed it in, or it will at least get as hot as it's ever going to get. Finally, I think you need to be fastidious about checking your microscope before you begin warming these oocytes. You should pass off this technique. Small variations in technique can have drastic changes in outcomes. Let's go over quickly the answers to the quiz. Does vitrification occur in slow cooling? We answered this. Yes, it does. Is the intracellular cryoprotectant concentration higher in slow or ultra-rapid cooling? One study actually indicates the concentration of the cryoprotectant is actually higher in slow cooling, despite us using higher concentrations for vitrification. And that's probably because the cells that are measured, where this concentration is measured, and I think it's mainly done in oocytes, spend more time before they get actually frozen. So they're constantly getting dehydrated out as they go down to minus 20 and minus 30 and even minus 50 degrees centigrade. Third, do current vitrification, does recrystallization or devitrification always result in cell death? Fortunately for us, it doesn't always. There have been studies that are done that when they begin a vitrification protocol and they use a microscope and look at the solution, sometimes there are very fine crystals, ice crystals that are formed, but they don't appear to damage the cells. Fourth, do current vitrification methods reach equilibrium? I've kind of alluded to that. They don't. The concentration inside the cell is often less than the concentration outside of the cell. And finally, why are two cryoprotectants used in current vitrification? They're less toxic. Finally, I want to offer an example of what can happen when you follow the meticulous methods and you think through how you're going to warm your oocytes or freeze your oocytes. This is with egg donors, so it's a very homogeneous group. The outcomes are very high. This was performed a few years ago in a clinic at Miami. And you can see fertilization rates, almost identical. Blastulation rates, almost identical. Our pregnancy rates I don't have here, but they were also almost identical. They were about 55%. What's interesting about this is this difference in 55% comparing fresh, which is in the white, to vitrified on the blue. Realize with fresh donors here, fresh oocytes, let me go back here. Right here, you might have 10, 20, 30 eggs. But with these vitrified cases, you have these great rates, pregnancy rates, and blastulation rates, even with small numbers of eggs, with 5 or 6. The only problem that we've seen is if you look over here, there are a certain number of patients that don't get an embryo transfer, and you have to be prepared to counsel your patient that they may not get a transfer. I know that's a scary thing for a lot of clinicians, and it's a terrible thing to have to face, and that's why some people still do a lot of day 3 transfers. But once you get over that hump, it'll be clear to you that you can have a much safer outcome for your patients by transferring fewer embryos. I thank you sincerely for your time, and I'm open to any questions. I hope I helped us catch up in time, too.
Thank you for this nice presentation, and the floor is open for any questions.
If the loss of temperature of the media from the incubator to hold the egg for work, this is a must. Why you don't start with a higher temperature? Like if you need the media to reach 37 when the oocyte is end. Why you don't put it in the incubator for like 38%?
Good question. So the question is, why don't we just leave the egg in the incubator? There's 2 reasons. One is that time in the media. The media. Actually, with cryotech media, the new media developed by Masako Ayama, you can leave it in overnight and pull it out. Once you take the media out and you're going to pipette it in, or you're going to dump it really, what you do is except for the first step, all that media is pipetted in because you want that to be at room temperature. Your dish is at 37, you dump that in to the dish, and you want to be plunging your device into that warm media that's 36 to 37 degrees within about a minute or so. So you do want to work very rapidly. You want to be totally ready. And then as soon as you dump it, all you have to want to do is uncap the device, or I often uncap it beforehand and then plunge.
My question, why you don't start with the media 38?
Oh, good question. You probably could, but I think we're all scared of going a little bit warmer, thinking we might cook the egg. But you probably could.
If the loss is necessary, it will happen. Why you don't start?
Yeah, and I don't think there's any harm in doing it at 38. And if it's a little bit over 37, I don't worry about it, and I think it's fine. The question might really be also, you bring a great point. Maybe we can even warm these at warmer temperatures. No one's really looked at it. We don't know that it's going to damage the egg. It may actually be beneficial to do it more rapidly and have less ice crystal formation. Unfortunately, a lot of these methods, I say they're done kind of empirically. I mean, there's research that's done to look at recrystallization, but once we have a technique, there's very little research done to see what happens to the solutions when we're using that exact technique. We don't know the concentration, for example, inside of the egg at the time of plunging into liquid nitrogen, the concentration of cryoprotectant. No one's measured that I know of.
Can I just ask, how important, how quick you freeze the eggs from collection?
Good question, yeah. We try to do it within an hour. We want to, let me put it this way, we like to start it within an hour. So we don't want to wait too long. I think the longer we wait, the more problems you have, but we all know we're left in a bind sometime. The man can't collect, and we don't know for 3 or 4 hours later, after trying several methods, we're left with still vitrifying the eggs. And you know what? We have good results from that. But we like to try to get them vitrified within 1 hour of after collection. We want to start vitrification and then warm them 2 hours prior to ICSI. Well, that's a good question. I actually always prefer the blastocyst stage, and I think there's several reasons. I think especially in the United States, where people are going more towards doing biopsies on a lot of embryos, maybe 50% of patients have biopsies on everything in some groups. And so I think that gets us more into looking at blastocysts. I really think, though, that doing the blastocysts, you've got a lot of give in how you vitrify and how you warm. If you kill half the cells, theoretically it will do fine. If you kill half the cells of a zygote, it's dead. That's the only cell it has. That is, and at least in the United States, almost every program that did zygote freezing have all changed to blastocyst freezing, or blastocyst vitrification. I should say, I don't know anyone in the US that isn't using vitrification now. And I would say the majority of places are using blastocyst stage. Although I think it's very, there are reasons to do, multicellular stage vitrification.
Thank you. I think we need to move on to the